Buenos dias, and welcome to the Advancing Women's Health in Central Texas webinar. I'm so glad you can join us today. For those who don't already know me, I'm Dr. Lourdes Rodriguez, and I serve as Senior Program Officer with the St. David's Foundation. If you would like to contribute to the conversation on social media, we ask that you kindly use the hashtag Focus on the Fourth, which is conveniently included in each one of the slides. Today's webinar is an opportunity for shared learning, but more importantly, for shared action. Our conversation is an important one because too many Texas women face poor pregnancy-related health outcomes. In Central Texas, we hold the horrific honorific of having the fourth highest rate of maternal death and rank equally high in other poor birth outcomes. Sadly, our Black sisters have the highest burden of both pregnancy-related morbidity and mortality. Since these differences persist even in the presence of protective factors such as education, higher income level, and other socioeconomic indicators, we need to go beyond individual level explanations to these differences and focus instead on how systems, structures, policies, and processes in our healthcare and social services facilitate or get in the way of better health for all. Today's presentations will highlight recommendations on what we can do together, that we can have better systems and structures, as well as foster the uptake of policies and new ways of working in service of Texas women. I would now like to introduce our colleague, Evelyn Delgado, who will serve as moderator for today's webinar, and she will then introduce our panelists. Evelyn Delgado is president at Healthy Futures of Texas. Healthy Futures' mission is to support development of strong families and positively impact the future of our community by reducing teen and unplanned pregnancy in San Antonio and Texas. She also serves as chair of the Texas Women's Healthcare Coalition, an initiative of Healthy Futures, which advocates for access to preventive healthcare, including contraception for all Texas women. A native of San Antonio, Evelyn is passionate about addressing the health needs of our community's teens, young adults, and families. Evelyn has extensive experience as a senior level executive leader in public health at the Texas Department of State Health Services, including overseeing women's and children's health programs. Using the principles of public health prevention, community health programs under her leadership, she served over 1 million Texans and delivered $950 million in public health services annually. Thank you so much, Evelyn. And now I'm going to pass the mic on to you.
Thank you, and good morning to everybody. Thank you, Lourdes. We would like to know, first of all, how many people are here from different areas of the state in terms of your role and the role of your organization. So we have a poll. So what sector best describes your role or the role of your organization that you represent? Take a moment to click. You'll have about 45 seconds to give us your responses, and this will give us a great opportunity to see who is with us today. So we have advocacy, clinical providers, funders, policymakers, and social services provider. So please respond to the poll, and we'll see where we are in a few seconds. All right. So you're hitting submit for poll question number 1. There will be a couple of others. So, okay, 36% of you are advocacy and clinical service providers, 16%, and funders, 25% funders. Policymakers, 4%, and social service providers at 20%. Quite a diverse group, and certainly everyone that we would hope to see on this webinar to learn more about women's health and the programs and challenges and also solutions ahead. So thank you very, very much for that. At this point, I would like to make introductions of our speakers. Eileen Nemi is an epidemiologist and population health scientist with the UT System Population Health, and she serves as Assistant Professor of Population Health at UT Health Science Center at Tyler. Her current work focuses on creating environments and policies that support health, diffusion and implementation science, and cross-sector collaboration. In her role with UT System Population Health, she serves as the program director for the Texas Health Improvement Network, or the THIN, and leads the Community Health Committee for the Texas Collaborative for Healthy Mothers and Babies. Welcome, Eileen. Adriana Kohler is a policy analyst and serves as policy director for Texans Care for Children. She collaborates with the organization's policy team on maternal health policy, leading the organization's work to improve infant and maternal health, promote healthy development during early childhood, and strengthen access to health coverage so that Texas kids and families can be healthy and succeed. She has played a leading role in advocating for access to children's health insurance, passing legislation to provide more Texas mothers with transportation to prenatal care and the very important postpartum care appointments, and passing legislation to ensure that 200,000 more Texas mothers have access to screening for postpartum depression, among other successes. Joyce James is the CEO of Joyce James Consulting, a firm based in Central Texas specializes on racial equity, with a focus on supporting and developing leaders towards a racial equity analysis using data and anti-racist principles that lead to systems transformation. She served more than 3 decades in state government, including being the first Black to head the Texas Child Protective Program, and was Associate Deputy Executive Commissioner for the Center for Elimination of Disproportionality and Disparities and the State Office of Minority Health at the Texas Health and Human Services Commission from September 2010 to September 2013. She serves on the board of Black Mamas ATX. Thank you, Joyce, and welcome. Before we formally begin with the presentations, and for those of you who are not familiar with the Texas Women's Healthcare Coalition, I wanted to share that TWHC is working toward the vision of a state where every woman has access to preventive and preconception care that will help her stay healthy and prepare for healthy planned pregnancies. We are a statewide organization and invite you to visit our website after this webinar to learn more about our work. And now, without further ado, I would like to introduce Eileen Mamie as our first panel presenter. Welcome, Eileen.
Hi, thanks, Evelyn. Thanks, everyone, for joining us today. I'm Eileen Mamie, and I'm one of the co-investigators, along with my colleague Divya Patel, on the PATH project, or Postpartum Access to Healthcare. PATH is a project of the Texas Collaborative for Healthy Mothers and Babies, which is our state's perinatal quality collaborative. And the project is supported by the St. David's Foundation. And we'd like to encourage you, if you aren't familiar with TCHMB, to please visit tchmb.org for more information, and that URL is available at the end of this presentation. This morning, I'm going to share with you some highlights from our first PATH project report, which focuses on the issues related to accessing the available public healthcare coverage options for uninsured women in Texas. So I'm going to give a brief overview of the PATH project just to start off. So broadly speaking, the goal of this project is to understand access to healthcare during the postpartum period from the perspective of women who do not have private health insurance, and also to understand how the state's women's health programs that provide healthcare coverage to uninsured populations are working on the ground. We have a team of bilingual and bicultural interviewers. They've conducted now over 90 interviews with 32 women who were either pregnant or postpartum, and we're interviewing them up to a year postpartum, interviews continuing this year. We've also conducted interviews with 20 clinic staff and healthcare providers who serve women in this community here in Central Texas. And for this particular report, we've also drawn on some publicly available data that's available on the Texas Women's Health programs. Many of you are probably well aware that Texas has an insurance problem or an uninsurance problem, and this is true for postpartum moms. So it's true for all groups, but it's also true for postpartum moms. So over a quarter of postpartum moms during that year following delivery in Texas are uninsured. And this uninsurance problem disproportionately impacts women of color. They're more likely than white women to not have health insurance, and this is one of many factors that contributes to maternal health disparities. There are several programs that are available that provide some coverage for healthcare costs if you're uninsured. And this is a simplified flow chart and just gives some information about 4 of the main ones that are available in Texas. Most pregnant people are eligible for some temporary pregnancy-related coverage, either through Medicaid for pregnant women or through CHIP perinatal. However, if you are an uninsured adult and you're not pregnant or disabled, your options are very limited in terms of public insurance options. There are a couple of what are called limited healthcare benefits packages that are often referred to as Texas Women's Health Programs, and those are Healthy Texas Women and the Texas Family Planning Program. So these programs are not full insurance programs. They cover a limited set of benefits, and certainly they don't address the larger systemic issues behind disparate access to health insurance, but they do play a very important role in filling the coverage gap. And we want to make the most of those programs and make sure that they're being used as widely as possible. And I want to mention this arrow that you see here, if we could just go back one slide, that the eligibility criteria for Medicaid for pregnant women and Healthy Texas Women are almost identical. And that's probably by design, I imagine. And so there is a mechanism to auto-enroll women when they complete Medicaid for pregnant women into Healthy Texas Women. And so that's what that arrow symbolizes. I want to take a moment here and do another poll. I believe someone will pull up the poll, and just to get a feel for the audience and where you are with this. So on a scale of 1 to 5, I want you all to let us know, how familiar are you with the Healthy Texas Women program? And I give it up to the poll manager to stop whenever you feel. Let's see what we get from our audience. Okay, so it's interesting. The largest plurality, I think is the term, are not at all familiar. Let's go on to the second poll. So this asks the same question on the scale of 1 to 5. How familiar are you with the Texas Family Planning Program? And again, almost half say they're not at all familiar. And so thank you all so much for sharing that. And I'll say that the responses that you all shared with us mirror much of what we heard in the community. Let's go on to the next slide. So I want to share a little bit about some of the key findings that we heard in an initial analysis of both the interviews with the staff and also with women. And one of the things we heard that we think there's opportunity for improvement is that there's a lot of misinformation or just confusion about these programs. And we think it's really important to close this information gap that exists across women, providers, advocates like many of you. And we saw that that was reflected in degree of awareness within this group. I'm just going to share with you a few quotes. So this was from a woman. She said, I think probably the biggest thing is that most women don't know this Healthy Texas Women program is available. None of my friends knew that if you don't have insurance and you're not working full time and you're making such a low income that there is still health care. This is a woman that was covered through Medicaid for pregnant women when we interviewed her. She said, I didn't have anything. This is prior to her pregnancy. I didn't have anything. I was under my dad's insurance, but he lost his job, cut off shortly after that, and I just had no forms of insurance. That was really, really, really tough. This is from a provider who had some confusion about, she is a Healthy Texas Women provider, but was a little bit confused about how to provide full coverage for her patients. So she said, if someone screens for diabetes or high blood pressure or something like that, that's my fuzziness of, okay, how do we make that transition into the next step and get her the care that she needs and have it reimbursed through Healthy Texas Women? So the second area for action that we've identified is there's a need to improve the processes that facilitate women's transition between Medicaid for pregnant women and Healthy Texas Women. And I mentioned that these two programs have almost identical criteria, and there is a system in place to auto-enroll women, but there's reason to think from what we heard that system maybe isn't working as fully as it ideally would be, and information about that isn't as widespread as it needs to be. And here are some of the quotes that we heard. So this is from one of our early postpartum members. That's probably my biggest complaint. It's just figuring it out. I think I get kicked off my insurance at the end of this month because I have the pregnancy Medicaid. So I think now that I'm not pregnant, it expires. This is from a staff member. We verify the coverage prior to them going through the financial screening. And that's when we verify that mom, in fact, does not have Healthy Texas Women and her Medicaid ended a month or two ago. Another quote, my understanding is that some people are automatically transitioned to Healthy Texas Women if they have Medicaid. Would like to know who is going to be automatically transitioned and who isn't. This is a social worker that works with clients. We need to improve that transition so that those moms can continue to have the coverage that's available to them after they transition off of Medicaid for pregnant women. The third area has to do with the family planning program. I think this program tends to receive a little bit less attention than Healthy Texas Women, but it's a very important program because its eligibility criteria are much less strict than Healthy Texas Women. You don't have to be female to qualify, and you don't have to be under 45. There's a slightly higher income you can earn, and you don't have to be a documented U.S. citizen. The benefits package is a little bit smaller, but one of the things it covers is vasectomies. Men are eligible for the family planning program. So this figure just shows you one of the big challenges of the family planning program, which is that it is essentially a grant. And so this is showing the number of clients served by month from fiscal years. And you can see that there's a drop off at the end of the fiscal year and then an uptick again. And that's because the money runs out. And we know that women's needs do not follow this pattern. This is a pattern that is based on the availability of money. And so some of the quotes will reflect some of this experience. So this is from an employee of a clinic that does not have the family planning program, but other clinics in her system do. And she said, and then they don't want to add us to the family planning program. They said, well, we'll run out anyway, so what's the point of adding you guys, because we'll just run out sooner. Another quote, you can't necessarily say to a patient, when you get done with your pregnancy, these are your options. It's really difficult to explain to somebody. So we get so much money a year, and when that's all out, you have to pay for it yourself. Last quote, this has to do with the range of what's covered under family planning program and how the money may actually be able to be spent. So if they want a tubal, chances are they're not getting it, because the funding that we get from the state through family planning program is not enough for the demand of what we have in our system. So meaning if they spend a lot of money on more expensive services like tubal ligations, that means there's less money available in the pot for other services. So on paper, tubals are covered, but in practice, they may not be covered. These are our selected recommendations. Please take a look at the report, and I'm happy to take some more questions at the end. Thank you all for your time. And I'd like to pass it over to my colleague, Adriana Kohler, who will share about her projects.
Thank you so much. Hi, everyone. My name is Adriana Kohler. I am Policy Director at Texans Care for Children. It's an honor to be with you here today. For those who are not familiar, Texans Care for Children is a multi-issue children's policy organization. We work statewide to advance policies that improve the health and lives of Texas kids. We work on a variety of issues, from maternal and child health to early childhood and children's mental health and foster care. Today, I'm going to talk about a project we worked on to engage stakeholders, health providers, communities, families across Texas to understand some of the challenges and opportunities in maternal mental health. So we'll talk about some of the key takeaways from our research and action steps needed to better support new moms struggling with maternal mental health challenges. For those who may not be familiar, maternal mental health challenges may be called postpartum depression, maternal depression. There are different phrases for it. It's one of the most common complications of pregnancy. 1 in 7 women in Texas will face maternal mental health challenges, either during pregnancy or up to a year postpartum. The impact for moms and babies is huge. A new mom may face crippling anxiety, severe depression, PTSD as she's trying to bond with her baby or help her baby grow and play. In addition to the suffering for moms, untreated maternal mental health challenges affect a child's language, cognitive development, behavioral health, and academic success later down the road. So while moms of all backgrounds are at risk, maternal mental health challenges disproportionately affect Black women and teen parents. Black women are also less likely to receive treatment compared to other moms. That's important to note. And the coronavirus pandemic and recession exacerbate some of these challenges facing new moms. About 600,000, so more than 500,000 Texas adults have become uninsured in the last few months during the COVID pandemic, and now 1 in 3 Texas adults are uninsured. Also, added stressors and isolation during this time of social distancing leave new parents and families on an island like never before, which may increase the risk of maternal mental health challenges. So let's talk about what we did in this project. In early 2020, we did a 6-month community engagement project around maternal mental health. Our goal was to learn from health providers, moms, families, to better understand challenges and opportunities. Based on that community engagement, our objective was to identify some specific action steps to improve screening, referral, and treatment of maternal mental health challenges. We had a second goal. We wanted to utilize this information gleaned from the community, from our survey and stakeholder engagement, to provide that to the state as they were developing a 5-year postpartum depression strategic plan. As context, in 2019, a bill passed that directs the state to develop and implement a 5-year strategic plan for referral, screening, and treatment of maternal mental health conditions. So it was good timing, and we worked closely with the agency during this process. So what did we do? We first researched efforts in other states and local efforts. We set up an incredible advisory group of more than 20 maternal health and mental health experts, neonatologists, pediatricians, OBGYNs, support group leaders, really fantastic group. And it spanned from Texarkana to Corpus, Houston, Dallas, El Paso. We also developed and circulated an online survey to gather information on what's going well with screening and referral, what's not going so well. And we developed and submitted some action steps for the state to improve screening and treatment. And we worked closely with the agency throughout this process. So let's talk a little bit about what we found. I won't spell out all our findings. You can see in today's event Evite for today's webinar and on focusonthefourth.org, you'll see a link for a report outlining all of the survey findings and then all of the recommendations. But I'm going to talk about the highlights now. First, our survey and work with stakeholders showed there is a desperate need for more training specific to maternal mental health. And this is for a broad range of providers. Professionals want to know more about the signs and symptoms, how to do screenings, how to refer, where to refer a mom who's suffering. Trainings are needed for a range of folks from OB/GYNs to pediatricians, WIC staff, mental health peer specialists, home visitors even. Second, the research revealed that pediatric providers are a critical touch point with new moms. New parents go to see their pediatric provider many times in the first few weeks and months and year of a new baby's life. And some parents have ongoing contact with their neonatologist or NICU staff if their baby is in the NICU for a period of time. So these are opportunities to catch problems. Yet it became clear that pediatric providers still want more training on how to screen and refer. State policies need to incentivize pediatric providers around mental health screenings and provide them clear guidance on what to do, how to refer new parents to local resources. Further, one of the biggest issues that came up time and time again was a need for a statewide referral resource, something to help both families and professionals know where to go. A list of mental health providers in your insurance network is just not cutting it. A list of local mental health authorities across the state is just not cutting it. Providers and families need referral resources that include mental health providers with expertise in maternal mental health, local and online support groups, home visiting programs, information about telehealth options. From our survey, one of the top challenges that was identified is not knowing where to refer a new mom. When it comes to treatment for maternal mental health challenges, discussions often highlighted the lack of affordable health insurance. That was a top barrier. And when asked what to do about it, survey respondents said extending Medicaid health insurance from 60 days to 12 months postpartum and adding mental health benefits to the Healthy Texas Women program. Finally, telehealth came up a lot. The survey was out during the beginning of the COVID pandemic, so that might be a reason. Childcare issues and transportation issues were high on the list of barriers in our survey, and it was clear that telemental health is a critical need for new moms, especially those juggling many different kids, those without childcare or transportation options. So the state health agency, HHSC, issued its draft strategic plan this month, and they asked for public comment. Many of you may have commented. And the plan is to get a finalized strategic plan to the legislature by September 1st. Overall, the plan is a good start. The state has committed to hosting a training series on maternal mental health for clinicians as part of its Grand Round series. The plan recognizes the role of informal and formal peer supports. It talks about group prenatal care like centering pregnancy. It talks about mental health peer specialists, who are those with lived experience recovering from a mental health condition. It talks about how the state will add trainings for community health workers to understand signs and symptoms of maternal mental health challenges. The state also said it will add mental health services and counseling to Healthy Texas Women. This is a new initiative where the state is adding some benefits that will be rolling out in September 2020. We have not seen the full list of proposed benefits, but the plan does say that mental health will be added, counseling will be added, which is a great start. There's a lot more work we can do, and we have to work together to advance action steps in Texas. That means working with the legislature. That means working with the state agency, with local leaders in your community, with your health system partners to make some of these action steps a reality. The state's postpartum plan is just a start. There are other opportunities. In January, the legislature goes back in session, and we have the opportunity to advance some of these steps. So first and foremost, health coverage is a top priority, especially now during COVID and the pandemic and the recession. Medicaid cuts off at 60 days postpartum, and many moms become uninsured then, just when mental health challenges are cropping up. And we know 1 in 3 Texas adults are uninsured. So the state can extend Medicaid from 60 days to 12 months. That is a step that the legislature needs to take. It got some momentum last year and passed the House, but stalled in the Senate. So we need all of you to work to make it happen. The state has the opportunity to build on the new Child Psychiatry Access Program to add a perinatal component. So perinatal psychiatric access programs, they link primary care providers, OBGYNs, pediatricians with trained psychiatrists over the phone, over teleconsult, and they offer help with screenings, medications, answer questions on how to refer a new mom. 14 other states have perinatal psychiatric access programs, and other states have used the infrastructure of their child psychiatric access programs to expand into maternal mental health. In our state, the Texas CPAN, Child Psychiatric Access Program, is just rolling out, and the infrastructure is being built. So we have an opportunity to think about adding maternal mental health as an element in the future years. The state and health systems can also promote telehealth initiatives. We have some great opportunities here. The pandemic accelerated the need for an implementation of telehealth, especially in terms of behavioral health. Providers have seen a big drop in no-show rates through use of telehealth. At the state level, what needs to happen is state policies must ensure that Medicaid, CHIP, private insurance cover and reimburse for behavioral health services via telehealth, including audio only. Why do I say that? Audio only is really helpful in areas of the state that may not have broadband or fast internet connections and where families may not have a smartphone or a computer. Last but not least, pediatricians play a critical role. We need to incentivize and build capacity for screenings in more settings, including in the NICU, in the pediatric office. Pediatricians need resources so that they know how to help new parents get mental health care when they're struggling. And with that, hopefully that provides a little bit of flavor. Please take a look at the longer report online, and I'm happy to answer any questions during the panel. I'd love to transition to Joyce James from Black Mamas ATX to talk about her work.
Good morning, and thank you for the opportunity to engage in a bold and courageous conversation today that I believe is critically necessary in saving the lives of Black mamas. So I'm going to share today my groundwater analysis on behalf of Black Mamas ATX. So Black mamas are disproportionately dying during and shortly after childbirth. And these deaths are unnecessary, they are preventable, and they cannot be attributed solely to individual pathology. For Black mamas to not only survive, but also thrive, we must take a systemic approach and make commitments to creating an anti-racist healthcare system. So institutional and structural racism are at the and this racism has lived and breathed within all of our helping systems for generations. So let's take a look at the forms of racism that contribute to the outcomes. So we see structural racism at the base of these outcomes. And it's really, really important for us to understand that where we have been is at the individual level, and that we really have to dig deeper and begin to look at institutional and structural racism. And I want to just briefly define these different types of racism. So individual racism is where we often focus. That's important, but it's not sufficient. And most helping professionals do not come to their work to intentionally cause harm. And so we could get rid of all of the individuals that we could point to and say they're racist, and it wouldn't change the outcomes in our systems. but rather we have to focus on institutional racism. And this is why I have developed the groundwater analysis, because institutional racism refers to the policies and practices within and across institutions that intentionally or not chronically favor one racial group over another. So it's important that we know the collective impact of our systems and institutions. On the other hand, structural racism is a system in which our public policies, institutional practices, and cultural representations, and the norms, they continue to work in ways that perpetuate racial inequities. And it's a part of the dimensions of our history that have actually, for some time, allowed privileges to be associated with whiteness and disadvantages to be associated with people of color. Structural racism is not something that a few people or a few institutions choose to practice. And so when we're trying to bring ourselves into a conversation about racism, we have to understand that most often it's not intentional and it's not deliberate, but it works whether it's unintentional or not. And it's not something that a few people or institutions choose to practice. It cuts across all of our systems and institutions. So I want to introduce to you, this is a very shortened version of the groundwater analysis that we have been using in our work with healthcare professionals as part of our strategies for improving outcomes for Black mamas, is that racial inequity looks the same across systems. And so it must be examined in and across all systems so that we understand all of the impact that Black mamas are faced with, that it's not just a healthcare system, that it starts often long before they interact with the healthcare system, but it culminates at that point when it's time for delivery of their babies, the stress of racism over the life course. So we have to be conscious of how those systems work together. Systems contribute significantly to the racial disparities. So systems for turning the mirror to examine a culture that keeps race outcomes in place for research that really shows that race is a predictor of a person's outcomes, not only in health, but in research shows that healthcare providers, treatment and diagnostic decisions, and their feelings about patient influence by race. And so Black women often experience this from the time that they walk into the doctor's office. Things like, can I see your Medicaid card? Are you married? These are socialized beliefs that we have about Black women when we don't know anything else about them. All we have to do is see them, and all of those socialized beliefs began to kick in. So it's already been stated several times that Black women are 3 to 4 times as likely to die from pregnancy-related causes as their white counterparts. But, an important piece of information is that this disproportionate rate is higher than that of women in Mexico, where nearly half of the population lives in poverty. So we know that it's not just about poverty, but it cuts across racial and examine the beliefs that we have been socialized around, that Black women bear the burden for their outcomes based on our belief that they don't take care of themselves, or they won't follow the doctor's office orders, or that they're all on Medicaid and lazy and just really don't do the necessary things that they need to do. So it's not about just poverty, because it cuts across lines. These system-level disparities cannot be explained by a few bad apples, ill-intent doctors, teachers, police officers, etc. So accountable institutions do not place the burden solely on its individual members. Rather, they work to examine the culture that allows individuals to perhaps act in racist ways, whether intentional or not. So being an accountable institution requires the institution supports every member and makes every member accountable for operating out of an anti-racist lens. So we have to begin to raise the level of consciousness and move towards operating out of an anti-racist culture. Poor outcomes are concentrated in certain geographic communities, usually poor communities and communities of color. When women live in poor communities of color, the stigma of racism is magnified by how we have been socialized to view these communities that often result in understanding that where you live matters, that place matters in health, and that if you live in a poor community of color that's under-resourced, it will impact our health and our health outcomes. And we have seen this impact quite vividly recently in the impact of the coronavirus on Black and Brown communities, as well as what we have seen as it relates to the relationship that Black and Brown people have with the police department and with the shootings that have occurred. Systemic interventions and training can work to reduce disproportionality and disparities in health outcomes and improve outcomes for all populations, which is the ultimate goal of doing work by focusing on the institutional and cultural levels of the organization, is that when you raise the bar for those at the bottom, the bar is raised for all. Until there is to work to undo racism, well-meaning professionals will not realize their vision for why they chose this work. Black mamas will continue to die, and systems will continue to produce exactly what they were designed to produce. Thank you. I would like to now turn it back over to Evelyn Delgado for the discussion on this webinar.
Thank you, Joyce, for that excellent presentation. We have had an excellent round of presentations. We're now on the Q&A portion of our program, always a very exciting time for us to hear from the audience and to hear specific questions answered by our panelists. Please use the Zoom chat, the Q&A feature, or the chat to pose any questions that you may have. And while you're thinking about your questions and getting ready to submit them, I do have a couple of questions that I'd like to use to start things off. This first one is for Eileen. Lucky Eileen. Academia is an essential partner of public health, and we look forward to more reports like the excellent one that you presented this morning. In your research, did you identify differences in the barriers faced by providers and clients in rural areas versus the urban areas and communities?
Thanks for that question. So I would say that first off, we faced barriers in finding participants in rural areas. Definitely from our experience looking at access, it is much more available in the major metropolitan areas, in the 5 county areas. One thing that we did hear is that women who are in Travis County also have access, if they're low income enough, to the medical assistance program, or MAP. And women outside of Travis County don't have that kind of access. And I think that there are ways in which women kind of work around that issue of the requirement of Travis County residency and figure out how to access that. But one thing that did come up as well, interestingly, in the interviews with the staff, is that so many of them can't afford to live in Austin either. And so they were commuting in from very long distances. Many of the women were commuting in from long distances. And so there's this consideration, I think, even happening about where are we locating our facilities, and is it time to relocate them, given the effects of gentrification, that the locations of the clinics based on the previous population demographics has changed, and those brick and mortar locations are still located in certain communities where people are having to commute long distances to get to them. So we didn't hear from as many rural women as we'd like to, but we definitely heard transportation, and be interesting to see how now that telemedicine has just blown up, and which is something that is, I think, a really good thing, how that may help alleviate some of that access, some of those access issues in the rural areas.
And Adriana, I think you've encountered some of that too in your important work. Can you tell us more about that? Thank you, Eileen.
I think Eileen has it spot on. When there's so many women who are uninsured, the safety net programs in the large metropolitan areas like Houston, Dallas, El Paso, Austin, they have programs like MAP, which provide some assistance to get healthcare services. But in rural areas, that is not the case. And the providers are also not there. We heard from some OBGYNs that when they saw a mother struggling, they would have to send them 5-6 hours to a big city to go to a psychiatric facility or to get inpatient care or to find a mental health provider. The shortage of mental health providers in rural areas is definitely a big concern. Eileen mentioned telehealth. That is a solution. Another option is what I mentioned around the perinatal access program, which is teleconsultation with a psychiatrist, so that the OBGYN or pediatrician or family physician can have that knowledge base and feel empowered to maybe prescribe medications or manage the client in-house rather than sending to another mental health provider. That can help in some circumstances, definitely not all, but some.
Okay, thank you so much. And Joyce, I have a question for you. There's another one in the chat, but I've got this one for you first. In my many years of work in maternal and child health, I've seen statewide and community efforts to reduce infant mortality and maternal mortality. And I believe some policymakers and stakeholders are beginning to understand that institutional racism does have an impact on health outcomes. But based on the continuing numbers of mortality and morbidity, it seems to me that we obviously haven't found the silver bullet. How do we know, help us understand when we know we're exploring the right policies or systems?
Thank you. It's a very good question. And I would also say that in many instances, it's not about whether or not the policy is racist within its own language. It's often in the interpretation or misinterpretation of the policy. And the challenges that we have faced for far too long in even being willing to admit that institutional and structural racism is at the core of these outcomes in health and across all other systems is our resistance to talking about racism. And that resistance is based on our not having a common analysis, definition, and language, and being stuck in the I'm not racist, which is at that individual level, rather than at least coming together to be willing to struggle until we can raise our consciousness and together see what racism looks like in these systems. And just quickly, it's been my experience because I've had the opportunity to present during my years before the legislature. And often when you mention racism, people don't want to talk about it. It's like, we can't do anything special. We treat everybody the same. It's about all. But the outcomes are never the same. And race continues to be the number one predictor.
Thank you, Joyce. For Eileen, Dr. Namey, and then following that, another one for you, Joyce. Eileen, thanks for the excellent research. This is from an attendee in the chat. This will be helpful in our advocacy work. Do you have recommendations on how to increase awareness of the Healthy Texas Women and the family planning programs among eligible clients or providers?
One of the things that we're in the process of doing now is developing a concise, two-sided sheet. Evelyn is part of this process, so can be used by our folks who are working directly with eligible clients, and concise with the basic information that's needed. And we're doing this in partnership with folks who are actually on the ground connected to patients. So if anyone is interested in providing input on that, please email me. And so that's at least one tool. We want people to feel confident. Anyone who works directly with an potentially eligible woman, whether you work at WIC or you're a doula, you have some basic information that you feel confident you could guide that woman in the right direction to see if she can sign up for coverage. So in some ways, that's very micro. It's through on the ground connected. On a larger scale, I think it's through, us all communicating with one another. There are advertisements out there. Sometimes I've seen these billboards. You maybe seen them around. They popped up and they went away. But I think it's harder to really get a feel for what they're all about. It's a little bit, they're complicated, and it's really more, you have to kind of digest some information, unfortunately, about it. So that's the piece that we're doing. Please let me know if you want to be involved in helping us develop a good tool.
Wonderful. Thank you, Eileen. And then back to you, Joyce. You mentioned training as a way to disable systemic racism. However, the literature suggests that implicit training, at least in the workplace, is temporarily effective at best. How can we improve training to truly improve outcomes?
Yes, another good question. And just to say that we have to first use the language. We are more comfortable using language around implicit bias, which has the potential to greatly impact people at an individual level. And so training in and of itself is not enough. It's the beginning of a journey towards creating an anti-racist institutional culture. So it means that we have to commit to long-term professional development, examining data, understanding racism, supporting the members of our institutions towards having that higher level of awareness and consciousness, because none of us are actually trained in our institutions of higher learning, nor are we required to have an analysis and an understanding of institutional racism. And so we go to work in these helping systems absent that, and we're often not conscious of it. So it has to be an accountable institution that puts anti-racist policies and practices in place and doesn't leave any room for individuals to act out racism on an individual level. So that means it's ongoing work. You're creating a supportive culture, you're examining policy and practice, you're doing ongoing training. And at some point, the culture of the institution transforms such that it is so clear that it is operating out of an anti-racist culture, that individuals who don't value, buy into, believe will then weed themselves out, and it will no longer be about getting rid of individual bad out.
Thank you. That is certainly the goal for my organization at Healthy Futures, and I hope it's the goal for all who are on this call today. Thank you for that, Joyce. Adriana, we've got a question from the chat for you too. The issue of virtual visit capabilities has been one I've faced when trying to conduct such visits for OB, acute gen, postpartum appointments, and PMAD assessments. How can others join with Texans Care for Children in advocating for continued reimbursement for telephone-only visits, which we're seeing are vital to continued care during the pandemic, and adjusted visits scheduled, as well as a more appropriate tool for clinicians to meet their patients' needs in a more generalized sense? It's a packed question, but right up your alley.
There seem to be two parts. First, the screening tools and making sure that all different types of providers have the right tools to assess for maternal mental health challenges. And the second part seems to be how to get involved, right? On telehealth issues. I would say first sign up for Texans Care for Children website, our newsletters. We follow what's going on at the legislature. I think there will be more action next session. It will be a different session, of course, but there will be action around telehealth policies. There have been so many telehealth policies that have been successful during COVID in this time, and right now they're in place as emergency measures during the public health emergency, but some may need to be in place permanently, and we need state policy to do that. So that could be created at the legislature. Sign up for our newsletters to get involved. Also, definitely tell the agency, HHSC, reach out to them and say how successful telehealth has been for your practice, for your clients, so especially audio only, so they see that success. in action. They want cost-effective services to be implemented as well. When it comes to the screening tools, there are several validated tools out there to screen for maternal mental health challenges. I think training on the screening tools is a good start. There's a really great Texas Health Steps online module. It's free and it's available to, it provides CMEs for Medicaid providers, and it goes through the different validated tools, the Edinburgh, the PHQ, and it is one training that helps the provider go through the tool, see how you assess for a maternal mental health challenge, and have a discussion with clients. Getting those tools into more offices is a very important goal. And I think that the more training that the state does on maternal mental health challenges, the more the tools will be out in more offices. Thank you for that question.
That was a really multifaceted question, and we got an answer to all those pieces. Thank you. Here's another one from the chat. It says, thanks so much for this panel. This question toward Ms. Joyce James and others. How do MCH stakeholders in Texas approach and integrate the larger equity discussion into creating systems change, thinking about providers and policymakers? So, Joyce, if you want to jump in, or anyone else on that.
Yes. And I am answering from my experience in heading a large state system and working from an intentional and deliberate approach to specifically address the racism that existed in the Texas child welfare system for African American children, youth, and families, and Native children and families as well. And I believe that it has to start with the leadership of these organizations, because leaders role model and send both verbal and non-verbal messages to their members about what is important. Systems start to socialize their members to the institutional norms from day one through orientation and training. And so there has to be a space created within these systems, one that I call liberated, where people have to be willing to struggle but be safe. So you don't approach this work by pointing fingers and laying blame, because I don't believe that healthcare professionals or social workers or educators come to their work to intentionally cause the harm that we see in the outcomes when we examine the data. And so, sometimes people say, well, what can we do? And they're thinking these big, grandiose things. But first, we have to raise our level of consciousness and understanding and, have an analysis of institutional and structural racism, so that when we see it, then we are the first, because we know our work. We know how we have been working. We are the first to be able to become conscious enough to say, that I've often heard leaders say in the many institutions that I do work with across the country, I can't believe that's how we were doing it, right? And so we have to put ourselves in a space where we begin to have a common analysis and have a discussion. The other thing is that we have to have strategic plans for how to infuse and integrate that to all levels of the institution. And there are many pieces involved in that, including data, engaging the community, developing the leadership, doing cross-systems collaborations, or at a minimum, understanding the collective impact of systems and institutions, and how that collective impact can often lead to poor health outcomes. So it's that, and then it's about, the long journey of creating an anti-racist culture. There's no quick fix to the racism that has existed since 1619. There's no quick fix to it, but the first step is to be willing to open that space. And I had to bring people in to support me when I started to do that work. And just one last thing I want to say, because not a lot of people know that when I worked in child welfare, we were able to provide data and discussion to the legislature, and Texas became the first state in the country to have law requiring child protective services to address the racial disproportionality. But they gave us the resources we needed to have a philosophical and cultural shift to change our practice models, to hear from the voices of the people whose lives were so profoundly impacted, and to, listen to that in a respectful way, and to no longer ask what's wrong with the people, but to ask what has happened to them based on the culture out of which systems operate, and to begin to ask, how is it that the healthcare system excludes, exploits, oppresses, and underserves, and all other systems do the same things to the same communities and the same population?
Thank you,
I'd be happy to help you.
I remember and respect that groundbreaking work that you did many years ago. Thank you very much for that. I have another question for Adriana from the chat. It says, first, thank you for addressing so many issues. I would like to know if there's any policy work or advocacy for women who have complications during or after birth.
Great question. I think one important policy step that can be taken to address complications, I assume this means complications beyond maternal mental health complications. One important policy step is supporting the implementation of AIM maternal health safety bundles in hospitals. These are best practices and protocols that have been developed by experts to and they're for hospitals to catch issues early. There's a hemorrhage bundle. They use the term bundle, and it's a kind of list of best practices and protocols. A hemorrhage bundle, a hypertension bundle, an opioid use bundle. There is a maternal mental health bundle. So hospitals can implement these and have implemented these. And they've seen a huge drop in complications, scary life-threatening complications that happen in the labor and delivery room and the recovery room. We have 98% of hospitals participating in AIM bundles, and that is supported through efforts at the state health agency. The legislature has funded the agency to help hospitals implement these bundles. What we want to do is make sure that the legislature keeps funding the state health agency to implement these bundles in more hospitals across the state. There is even a best practices bundle around racial equity, so that hospitals implement race equity practices, disaggregate data, make sure they look through a race equity lens. I think that's an important way to really save lives and prevent those complications right at the beginning.
Thank you, Adriana. And Eileen, I know that with the TCHMB, the Texas Collaborative for Healthy Mothers and Babies, there's been a lot of important work done in that area as well. If you'd like to chime in with any of those, please feel free.
I think what I'd like to just encourage anyone who is not familiar with TCHMB, please come visit our website. I know that we're about to do a survey of organizations, and we'd like to learn more about what you're doing and you're interested in being involved with TCHMB. So again, send me an email and I can connect you with that, and please visit our website, and you can learn about some of the projects that TCHMB has been involved in. I think it's been about 5 years, I think now, maybe a little longer, you might know, that it's been up and running. And that's the State Perinatal Quality Improvement Collaborative.
Yes, and Texas is very fortunate to have one of these models to help improve quality of care for women. And in Texas, the TCHMB elected to also focus not only on neonatal and OB, but also to look at community. So a very important piece of that. And actually, the TCHMB is exploring ways to make sure that racial equity is addressed in the projects that it takes in the future. Thank you, Eileen, for all that work y'all are doing. There is a question to the panel. How have the economic benefits towards improved MCH outcomes influenced policy changes in Texas? I know this isn't an exact question to match exactly what you do, but in your work definitely does help impact having economic benefits in Texas through better birth outcomes, better health outcomes for mom, many different ways.
I can start. The economic benefits and the cost savings are so persuasive and powerful to policymakers, in addition to the improved outcomes for moms and babies. I think now more than ever before, as we enter the 2021 session, those economic benefits will be more important than ever. So, just as an example, untreated maternal mental health challenges cost the U.S. $14 billion a year because of worse outcomes to mom and baby, lost productivity and absenteeism at work, and issues. It covers the first 5 years of a child's life, so potential language delays, disabilities, etc. Mathematica has done a great analysis to look at the cost. So it really shows that we need to treat these conditions early to avoid those high costs to our state, to our economy, to our families in the long run.
Thank you. Thank you very much for that.
I was just going to say, in the spirit that I live and breathe by of the Undoing Racism analysis, is that it's been our experience that new programs and services that come out in response to these issues, when you really look at the data disaggregated by race and ethnicity, they still disproportionately benefit whites. And so they will continue to do that until we build that analysis in and come to an understanding that it's not always about more programs and services to fix the people, but it's about examining the institutional culture that they have to interact with. And when we make some changes there will be cost savings from that kind of impact.
Okay, an important point there too. Eileen.
Yeah, just wanted to follow up. It's just something that in public health we've been talking about forever, that prevention pays for itself, and that is true. The challenge is, and this is a term that I find useful, is there's this idea of the wrong pocket problem. So the pocket that's paying for the programs that are going to create that savings, that pocket's not the one that is benefiting from down the line when those savings are procured. So maybe that's in education benefits or in criminal justice system and so on. And so that's a challenge, and we need to have those cross-sector conversations. And one way to look at this too is it might be the wrong pocket, but it's the same pair of pants. So Texas is that pair of pants, and we end up paying for it one way or another, or the taxpayers. So understanding that, helping the legislature understand that we're all one pair of pants here. You can bear with my analogy, but we have to solve that wrong pocket problem, or we'll continue to underfund those services that will generate the savings down the road.
Eileen, I've never heard that pants analogy, but I will certainly use it in the future. I love it. Thank you. Here is a question for Ms. Kohler again, Adriana. Are there access limits to telehealth care? Have these barriers been experienced by women and families to receive telehealth services? So I guess this one is focused on the barriers on the women's side. Like, we know there are provider barriers and in trying to implement telehealth, but what are women and families experiencing?
Yeah, when we talk about access limits, it could take a few forms. Maybe an insurance provider limits the number of sessions. I have not seen that to be the case during the COVID pandemic, at least. But that doesn't mean that that's the case outside of the emergency. When we come to other access barriers could be the access to the software. Some of these virtual visits need certain apps, and that would need a smartphone. Many families don't have a smartphone or don't have a computer with broadband to be able to do a virtual visit. That's one of the biggest barriers I've seen.
Okay, thank you. I have a question again for Joyce. Is there an existing tool or institution within state government that can be used to distribute systemic intervention and training throughout all systems?
Well, I'm very happy to respond to that question because at one time, actually in 2011, the Texas legislature created the Center for Elimination of Disproportionality and Disparities. And it was a one-of-a-kind center in the country that got lots of recognition from colleagues across the country because Senate Bill 501 expressly charged that center to lead an interagency council. I was the presiding officer to examine outcomes, racially disproportionate outcomes in education, child welfare, health, and mental health. And a lot of tools were being developed, trainings for the different systems and their even some of their contracted providers. And what I say about racism is that it's been in place for so long that our systems and institutions were originally set up and designed to operate a certain way, that they are very resistant to change, and that as long as we are intentional and deliberate about going to the root cause of these issues and pushing against the walls of the institution and that resistance, we see the institutions give and we see good things happen for all populations, and we see the racial inequities gap decreasing. But as soon as you let up, the resistance in those systems operates such that systems go back to their old way of doing business. And so in 2018, I left in 2013, but in 2018, during the 2017 legislative session, the center was defunded, and it, in essence, shut down in 2018. And so I would say that if we had some opportunity to recreate a similar structure, because I think there's more of a commitment now, not just from the state agencies, but from different community-based organizations and other systems, that our awareness and consciousness around the importance of this has been heightened due to our current environment. And so I don't know of any such place in Texas that exists to do work in the broad spectrum, legislatively required way in which the center was created. I do work in healthcare systems, in education, and child welfare, because what we see in any one system at the core of those outcomes is the same thing, and it's institutional and structural basis.
Thank you. There was a question from about midwifery. Is there any discussion of making midwifery care more accessible in order to affect maternal mental health outcomes? Midwifery care includes the child's first 6 weeks of pediatric care and also multiple maternal checks in the first 6 weeks. Each visit is an excellent opportunity to notice signs, symptoms of perinatal mental health disorder. I'll turn this one over. And there is another mention that unfortunately, home birth and midwifery care is not covered even partially by most health insurance, which makes it inaccessible to even families with insurance. Adriana?
Yeah, that's a great question. To be totally candid, the issue of midwifery did not come up in our survey or in our listening sessions or from our advisory group. I will say that we had many folks on the advisory group and in the survey who had lived experience, personal experience with maternal mental health challenges. That said, the survey did show that home home visits broadly were one of the top recommendations to improve access to treatment for new moms. So better access, improved access to home visits. That could be through, I think we said an example of, doula care. We may not have said midwifery specifically. So there is a need or a desire for women to have more home visiting options in that postpartum time. But I think you bring up a good point. I think now with the COVID pandemic and the new world that we're in, more folks may be choosing home births and alternative options, including midwives, and we need to make sure that access, including coverage, is there.
Thank you for that. I will go to another Q&A because we did have some. There is one, it says, I'm a faculty, first of all, thank you for all the excellent presentations. I'm a faculty member in the College of Pharmacy and would like to know your thoughts on what we can do in our profession, either in practice or research, to contribute to this area. Of note, community pharmacists are prevalent in many communities, especially rural areas, and could help screening and or dissemination of information. Please also consider including them in training opportunities.
Just say thanks. I made a note of that. It's such an important reminder that of the role, especially in rural communities, that the pharmacists play. And I'm glad that came up. And we will definitely include pharmacists in our, thinking about how to provide more education around the available healthcare coverage programs.
Okay, thank you. And thank you to all the questions from the audience. We really appreciate the richness and your critical thinking about what we can do in the future and what educating yourself on the role that you can take with others. We have about 6 minutes left, and we'd like to do a quick round robin through the panelists to just share a thought or two, an action item perhaps, on what can be done to advance women's health from the work that you're doing. And then after that, Lourdes will come up next to close us out. Adriana.
I'm going to start. Yes. I love the call to action. I would say sign up for several of these different organizations, including the Texas Women's Healthcare Coalition. They keep stakeholders educated on what's going on at the legislature and with policy. That's a really great way to get familiar with the Healthy Texas Women program. We saw a plurality was not familiar. Let's get educated. Let's make sure we know what the programs do and don't do, and make sure they have funding. Another action item is to sign up for Cover Texas Now. It is a coalition of broad groups all over the state, and the main mission is to improve access to healthcare coverage. And it's a great way to get involved and understand what's going on at the legislature.
Wonderful. And I'll put in my plug. Vote, vote, vote. Vote.
Can I just say that?
Changes. Okay, Joyce. Sure.
I was just going to suggest that that providers consider hosting a groundwater analysis workshop that would include engage in that session, so that we could hear the real life experiences of the people who are impacted by these issues, and that we could talk about examining policy and practice and some of the changes that could go forward in addressing the issue, so that all moms have a great opportunity for a healthy birth outcome.
Thank you, Joyce. And Eileen?
Well, echo those great suggestions. And I would like to just encourage anyone who's not familiar with the Texas Collaborative for Healthy Mothers and Babies to stop by, visit the website. There are opportunities to get involved. The community committee is unique. We're not just about hospitals. So if you are interested in getting involved at the state level, please take a look at what's happening with the TCHMB.
Thank you. Great. Thank you for those action items. And now I would like to turn the mic over to Lourdes for closing remarks. Thank you.
I want to ask all of our participants to join me in thanking our presenters and our moderator for a great discussion. And thank you for so much for participating today. But I have one last ask from each of you. This is the action portion of today's program. And it is intentionally at the end, because as we go back to our organizational homes, we want to invite you to think about what is yours to do to help advance women's health in Central Texas. So I would like to please cue our last poll of the day. And we are inviting you to think about which of the following recommendations shared today are you and your organization able to move forward. We've listed recommendations that come from the reports from the groundwater analysis, and we invite you to click. You can select multiple ones. You are not only restricted to selecting one, and that will give us a sense of where there is congruence of ideas, where there's opportunities to continue to follow up after today. And now that you've reflected on what is yours to do, and you have selected an area of work that is aligned with your work, I would like to remind us that we are responsible for holding each other accountable and encouraged to help advance women's health in Central Texas. I can't wait to see the poll results. I know that is a little bit long. Thank you so much to all of the folks behind the scenes for making this a great event, everything smoothly. Thank you so much. And last but not least, I want to say mil gracias. And I hope that you and yours are safe, healthy, and at ease, and that you join us in the next event that we put together here at St. David's Foundation. Thank you so much for joining us today.